So good afternoon, everyone. Thanks for those who have joined us. This is 2:01 p.m., so just a few seconds off of our scheduled start time. But thanks again. This is our 77th episode, iteration of MRF HIVSTI Echo. I am Dr. Voice. I'm the picture in the corner this time. I'm not at MRF today. I'm away at home. But nonetheless, I'm very happy that you could come, happy that you could participate in today's session. And again, I welcome Dr. Edwards and welcome Conrad, as usual, for being our bedrock of support. So today is, again, one of our special Friday sessions. And today's speaker will be Dr. Chris Behrens, again, who we wish to thank for all the support over the years. And again, bring us up to date on the two pandemics, one new, one not so new, that seem to be causing us still a lot of concern, still a lot of preoccupation, especially among public health professionals, how to bottle these two outbreaks up. So, and those two things, obviously, are monkeypox and COVID-19. So, Dr. Behrens, I shall turn the floor to you, and thanks again for your usual great support.
Absolutely. Thank you. It's always a pleasure.
Hi, Mary.
Let me get this going. I think we have some background noise. Okay, here we go. Let me get this launched. There we go. All right. So, first of all, I want to acknowledge the contribution of some of the slides I'll be presenting by a colleague of mine here at University of Washington and King County Public Health, Matthew Golden, who's really been doing a lot of extraordinary work with monkeypox lately here in Seattle. I want to acknowledge our sponsors as usual. I have no conflicts of interest. Our learning objectives are as shown. Essentially, I'm going to talk a little bit about epidemiology of COVID-19 recently, some concerns about long COVID, and mention the new bivalent COVID-19 vaccines. And then I'm going to talk a bit more, actually, about monkeypox. And I know Dr. Edwards gave a terrific review of this. I'm hoping to add a little bit more information and maybe an update of sorts on that. So in terms of COVID-19, fortunately, globally, we are seeing some improvement. Cases are definitely on the decline throughout most of the world. They are on the decline here in the United States as well. In Trinidad, there's been a decline also, perhaps not quite as much as we have seen, relatively speaking, in the world overall. But the numbers are certainly not as high as they were at the height of the first, like, Omicron wave, for example. The most recent wave, of course, was probably driven by BA4 and BA5 subvariants of Omicron. So there's some good news there. But I want to emphasize, the importance of being wary and vigilant and trying not to get COVID. There's increasing recognition of what is called long COVID, also known as post-acute COVID syndrome, or PACS. This is sort of an evolving condition that we're still trying to, understand, but it's clearly a very real thing. And it refers to the fact that many people who get COVID don't get better right away. And in fact, have really, it can be a pretty broad constellation of symptoms and signs that can continue for months following COVID infection, even if the initial infection was relatively mild. Interestingly, there's a lot of overlap between what we're calling long COVID and what is known as chronic fatigue syndrome / myalgic encephalitis, or ME/CSF. Also a poorly understood condition, but it's thought that there may be a similar pathophysiology undergirding both of these conditions, given just how similar the overall clinical presentation is. We're still trying to, define exactly, how long do you have to have these symptoms after COVID in order for it to be called long COVID? How long do they need to, persist, et cetera. But we're starting to get some stuff from the literature. I'm going to briefly mention this recent survey done in the United States because it had relatively large numbers, and I think it provides some useful information. In this study, long COVID was defined as symptoms persisting 4 or more weeks following a COVID illness, regardless of the severity of that illness. The survey identified over 1,000 patients and asked about long COVID symptoms of those. And I want to, it's a very busy slide, but I want to highlight a few things. First of all, overall, 21 or 22% of individuals who had COVID continue to have symptoms more than 4 weeks after the initial illness. That's 1 in 5 individuals. That's a very high proportion of individuals. And for many of these individuals, it's fairly disabling. I have seen patients who have this, and they, generally speaking, are really struggling with going back to work. They either cannot return to work at all, or they're having to work part-time. Similarly to chronic fatigue syndrome, it's almost a real intolerance of any sort of exercise or exertion. So they might go to work, for a few hours, and then they're just exhausted and they have to take the next day off. The other things that are worth pointing out, besides the relatively high prevalence of it in this survey, in terms of age groups, we're seeing it across all age groups. Interestingly, there was less of it among older individuals. Not sure if that'll hold up with further study, but kind of an interesting finding. Definite predominance among women, females more at risk than males, which is similar to chronic fatigue syndrome. And then sort of disappointingly, vaccination status didn't seem to make a huge difference here. It does look like maybe there's less of a risk of it if you've been fully vaccinated and boosted, but it's not a tremendous difference. So you just don't want to get this because long COVID is a real thing. It can be pretty disabling. And according to at least this survey in the United States, it affects about 1 in 5 individuals who have had COVID. So, we know what to do in order to minimize the risk of getting COVID. We know what to do in terms of limiting its spread within the population. We've just got to stay the course with the interventions that really make a difference. And again, I show the Swiss cheese respiratory virus pandemic model, which kind of emphasizes that there are many individual interventions that can make a difference in reducing the risk of COVID infection and spread within a community. No one of these slices in the model is perfect, but when you add them all together, it makes for a pretty substantial barrier. Now, that last one, vaccines, I'm going to transition to talk about the fact that we do have some progress on that front. So you may have heard that there is now a new updated bivalent COVID booster that was just approved by the United States Food and Drug Administration and endorsed by the CDC. That is recommended essentially for all individuals 12 years of age or older. These are updated formulations of both the Moderna and Pfizer vaccines. You may recall these are messenger RNA-based vaccines. And in fact, they have also proved to be the most effective vaccines we have. And what they've done is they've modified these vaccines to include both genetic material or coding to protect against the original Wuhan strain of COVID, but also some new material that is specifically geared to protect against the Omicron variants. So that's why we call it bivalent. There's sort of 2 components now to it, the old one plus this additional that protects against Omicron. The Moderna one is approved for individuals 18 years of age or older, Pfizer 12 years of age or older, They have both been approved as of last week, and we anticipate getting them, more available throughout the United States in the coming weeks. I really don't know what the plan is for international distribution at this time. The authorization was based on basically in vitro data and from a study involving about 800 individuals, improved immunogenicity as compared with the original messenger RNA vaccines, and roughly equivalent safety data. So we'll see how that pans out, but hopefully this new bivalent vaccine will be coming your way, and it is highly recommended. Now, I'm going to transition to monkeypox, and I'm going to start with a little review of the phylogeny and epidemiology. Monkeypox is known as an orthopox virus. It's a DNA-based virus. It's in the same genus as variola, which causes smallpox, as well as vaccinia, which is the basis of the smallpox vaccines. And historically, there have been two major clades. The C1 clade, which is typically seen in Central Africa, that is a more virulent strain, and the C2 strain, typically seen in West Africa. This particular strain seems to be less deadly, lower mortality rate, and fortunately, the current outbreak stems from that C2 clade. And essentially on the phylogeny tree, it's the yellow circled strains up in the far right corner that we're dealing with in the current outbreak. In terms of transmission, this is a zoonotic disease. Rodents are actually thought to be the natural reservoir. Monkeypox is a bit of a misnomer. It was named monkeypox because it was originally found in monkeys, but that is, not the natural host. Animal to human transmission occurs via body fluids or contact with mucosal lesions, and then human to human transmission occurs via direct contact with infected lesions or fluid, frequently spreading during intimate contact. And that's really been what the driver of this current epidemic. There may be other potential but less common modes of transmission. It would not be at all surprising to see that this could be transmitted by fomites, say contaminated bedding or towels, etc. There's also some evidence from distant past outbreaks of potential respiratory spread, but this does not seem to be the way that it is being transmitted in this current outbreak. It seems to be, we are not dealing with another coronavirus in that sense. It really is intimate contact that seems to be the driver for all the cases we are seeing so far. Now, is it an STI? I mean, I'd refer to intimate contacts as being the driver of transmission. Well, I mean, you could call it an STI or STD, but we have to acknowledge that really for many pathogens, this distinction between STI versus non-STI is a bit hazy. Many infections not considered to be sexually transmitted can actually be transmitted sexually. Think of Shigella, hepatitis C, or Ebola. And then many infections considered to be STIs can actually be transmitted via other means, HIV, syphilis, hepatitis B. So it's ultimately not necessarily all that helpful to get hung up on whether this is an STD or STI or not. I think it's reasonable to simply consider this as a sexually transmissible infection. In the current outbreak, infections have been mostly, the vast majority, traced to sexual encounters among gay, bisexual, and other men who have sex with men. But that transmission is likely occurring from skin-to-skin contact during these encounters, perhaps from kissing and saliva. All right, in terms of the history of it, it's kind of interesting because monkeypox was first identified in Africa, and we have some historical trends from the DRC showing that the incidence of monkeypox infections increased dramatically after routine vaccination against smallpox stopped in 1980. And this is how, part of the reason why we know that these smallpox vaccines are very effective at preventing monkeypox. And if you look closer at the recent incidence of monkeypox in the Democratic Republic of Congo, in recent years, this was done looking at 2006-7 versus the early 1980s. Clearly, big jump in cases in the late 2000s. But that increase in cases was really far more likely to occur in younger age groups rather than older. And the difference, of course, being the older folks tended to have been vaccinated against monkeypox. And so from this, and as well as a dedicated study actually looking at the effectiveness of monkeypox, of smallpox vaccination, we know that these smallpox vaccines seem to offer about 82 to 85% protection against monkeypox. So that's good news. With this outbreak, we know that we actually already have vaccines that work. Now, the epidemiology of the current outbreak, the cases have continued to climb, at least the cumulative cases, worldwide. And the current outbreak seems to be confined mostly to Western Europe, North America, and definitely some cases creeping up in South America as well. But fortunately, overall, it looks like the number of cases, new cases at least, has peaked. We've seen a decrease in the past few weeks in the number of new cases, and this is mirrored in what we're seeing, here in the clinic where I work. In Seattle, for example, for a while we were seeing several cases of monkeypox per day walking in the clinic. It's definitely dropped off. Too early to say that we've turned the corner on this, but encouragingly, at least it seems like we've reached a kind of a peak in terms of the number of cases. I don't have any data, about where things stand. In Trinidad, but if somebody has those data, perhaps we can talk about it later. We get a little bit more detailed epidemiologic information from the United Kingdom. They recently had identified 445 cases for which they had what's called enhanced surveillance, basically more detailed data about the individuals who had it. 96% of them were of these cases occurred in gay, bisexual, and other men who have sex with men. Just about half had had some sort of STI in the past year. 30% of them were among people living with HIV. Among the HIV negative individuals, 79%, very, very high percentage, were on pre-exposure prophylaxis or PrEP. So individuals on PrEP are definitely in a very high risk group. 31%, about a third, had had 10 or more sexual partners in the past 3 months. None of these cases seem to occur via airborne transmission. 10% were hospitalized. Deaths in this current outbreak are very rare. There's been one death here in the United States. Today, it occurred in someone who is very immunocompromised. All right, let's talk a little bit about the clinical course. And classically, monkeypox disease has an incubation period, then a prodrome, and then a rash. Incubation period is this period, like any incubation period, where someone has it, but they're typically asymptomatic and not contagious. The incubation period historically for this disease has averaged 7 to 14 days. But with the current outbreak, it's actually a lot less than that. It seems to be more like 3 to 7 days. It's far more typical. And that's an interesting finding that, I have not seen a clear explanation for why that is. Following that, classically, there is a prodrome, an early set of symptoms. that typically includes fever, malaise, headache, sometimes sore throat, cough, lymphadenopathy. This is something that typically the lymph node swelling occurs with fever onset, maybe before the onset of the rash. And they can be in various areas: neck, armpits, groin, can be unilateral, can be bilateral. And then the last period is the appearance of the lesions. These lesions develop in any mucosal surface or on the body. They progress through stages before falling off. People are considered contagious from the onset of these lesions throughout the period until they scab over and fall off. Now, having said that, with the current outbreak, we're seeing a bit, some differences from the classic sequence here. As I already mentioned, the incubation period seems to be less. The other thing to know is that the prodrome is often very mild or even absent, and is sometimes sort of occurs right at the same time as the onset of the rash. So it's almost as if the whole process is being compressed a bit, with a much less of a prodrome and sometimes no prodrome whatsoever in many patients. So furthermore, many of the lesions are occurring right at the presumed site of inoculation. And then they may or may not develop lesions elsewhere. So because this is so frequently associated with sexual behavior and intimate contact, we are tending to see these lesions occur on the genitals, the perianal region, proctitis, a very common site, in the mouth or the pharynx. Sometimes the predominant complaint is sore throat. So it can look a little bit like mono, at least in terms of symptoms: fever, sore throat, lymph nodes. But on inspection of the oral cavity, it looks quite a bit different from mononucleosis. Again, the prodrome may be mild or absent. So the key is to have a high index of suspicion and a low threshold for testing, especially if this is an individual who's among one of the high-risk groups. There was a recent survey or review of this published in the New England Journal of Medicine of 528 cases. Sort of similarly to the UK data, 98% occurred of cases where men would have sex with men. 95%, the route of transmission was established to be sexual or intimate contact. Rash, skin lesions occurring in virtually all of them. Arguably, without that, they probably never would have been diagnosed. Mucosal lesions were very common, though. Worth noting, nearly half of them had mucosal lesions. Fever occurred in most, as did lymphadenopathy, but some of these other prodromal symptoms were actually occurred in less than half of the individuals. So I'm going to show a lot of photos here because I think it's important to sort of be familiar with what this can look like. This is actually comes from that article in the New England Journal describing a single individual's case. And I think this case is fairly typical on day -4, so 4 days prior to anything was the sexual contact. And then just 4 days later, again, relatively short prodrome, genital lesion appeared. It was thought to be syphilis and empirically treated with penicillin, but that didn't do any good, of course. And so this individual continued to feel unwell, developed additional lesions on days 4 through 6. Eventually on day 11, nearly 2 weeks later, was confirmed monkeypox with facial and genital lesions that were PCR positive for the virus. And then though the lesions, there was no treatment of this individual. On follow-up, 3 weeks out, the lesions started to test negative on the face. And then 4 weeks out, negative on the genital region as well. And those are some of the photos showing sort of the sequence of those lesions on the face and genital region. Here are some more examples of what these lesions can look like in oral and perioral regions. These are photos from the current outbreak, and it's worth noting what it can look like in the oral cavity. That can look like aphthous ulcers, for example. Around the lips, it could resemble even angular cheilitis. So there has to be, again, a high index of suspicion and a low index, a low threshold for testing. Rectal, anal, perianal lesions, also very common. In most of the cases I have seen so far have been a case of proctitis, actually. So this is what some of those lesions can look like. It's a bit easier to, make the diagnosis when there are multiple, but sometimes there's only, small ones. They can look, honestly, a lot like herpetic lesions. So it can be difficult to distinguish exactly what it is without confirmatory testing. There is a sort of classic sequence of how they can appear. Typically, these start out as an early vesicle and then transform into a small pustule that umbilicates and ulcerates, followed by crusting and resolution. And that typically occurs over the span of 2 to 3 weeks. Here's some more. I'm just going to show a bunch more lesions and photos of this so you can be familiar with it. Note that these lesions can occur on the palms and soles. So worth noting that. We tend to think of those kinds of lesions as being secondary syphilis, but monkeypox can clearly be confused with that. This is not from the current outbreak. This is from an older outbreak, monkeypox on the palms of a child. Again, note the potential similarity and possibility of confusion with secondary syphilis. Another picture of the lesions in various stages of healing on the torso, on the hands and wrist again. More lesions. These are some more recent lesions taken from our own STD clinic. And that's a pretty subtle lesion. That to me looks like just a little bit of folliculitis, but it was positive for monkeypox. Here's a similar lesion on the leg. To me, I would suspect that might be a MRSA bacterial infection, but that too turned out to be monkeypox. Monkeypox lesions on the palm. To me, that looks more like secondary syphilis, but it turned out to be monkeypox. In the oral cavity, again, that could easily be confused with an aphthous ulcer or a herpetic ulcer. On the penis, those are pretty classic lesions of monkeypox with the umbilication. Also on the scrotal region, again, you see umbilication and you see swelling, redness in the area. Lymphadenopathy in the inguinal region would be very commonly seen in a presentation like this. More lesions that look a bit less classic, but turned out to be monkeypox. Again, that could easily be suspected as being impetigo or a herpes outbreak. Proctitis lesions, more genital lesions. Actually, this is genital herpes. So again, very similar, almost impossible to clinically distinguish just from the appearance which one we're dealing with. Disseminated cryptococcal infection, of course, can look a lot like monkeypox with umbilicated pustules. Molluscum, similarly, umbilicated lesions closely resembling monkeypox. Not surprising, molluscum is caused by a pox virus as well. Secondary syphilis, which I showed earlier. Primary syphilitic chancres can be confused with monkeypox lesions, as can secondary syphilis. And the condyloma lata associated with secondary syphilis. Now, these look a bit different from monkeypox. Again, a genital herpes lesion, herpes zoster. That could be confused with monkeypox. The unilateral distribution makes it less likely to be monkeypox, but I don't think you could clearly know without doing a swab to test for both. Disseminated gonococcal infection can cause lesions as well, especially at joints. That could be confused with monkeypox. So just to summarize some of these key characteristics, the lesions of monkeypox tend to be well circumscribed, deep-seated. They often umbilicate, and they're often pretty painful. And we do need to think about pain control in individuals. For example, the proctitis can be a very painful situation. Lesions are relatively the same size and same stage of development at any single site of the body, right? Although at different parts of the body, as we saw in that New England Journal case, they might be evolving on a different timetable. Fever tends to occur before rash, if at all. Lymphadenopathy is common. Disseminated rash, when it occurs, tends to be more on the extremities and face than on the trunk. Again, we see them on the palms and soles, and they're often painful until they heal. As they heal, they're often itchy during the crusting stage. There are, we know, asymptomatic infections. This was an interesting study done at an STD clinic in Belgium, where they retrospectively retested some samples they had, and they found that 3 of the people who had been tested for asymptomatic, basically screened for like gonorrhea and chlamydia, it turned out that they had PCR test positive for monkeypox. So we know that asymptomatic infection can occur. What we don't know exactly is how often this happens and how much, if at all, that contributes to transmission to other individuals. We also know that we can recover monkeypox from a number of different anatomical sites. This was a very small study done in Spain, but they recovered monkeypox from all these different components, from saliva, from rectal area, nasopharynx, from semen, urine, even from feces, up to 16 days following symptom onset. While we know that we can recover the virus, we don't know if that means it is transmissible from these various different body sites and fluids. So we're going to need a lot more information before we can comment about that. But I think for the time being, it's worth keeping in mind that all these various fluids can have monkeypox in them. And so it's, I think, worth being more on the cautious side around these fluids when coming in contact with them. In terms of prognosis and complications, the overwhelming majority of patients will do well. In some of the older series studies of the C1 clade, remember that was the more virulent strains, the case fatality rate was up to 10%, but in the more recent ones with this current outbreak, very low case fatality rate. I wrote here none in the US. I need to update that. Very recently, a case was reported of a death in a very immunosuppressed individual. And those are the individuals who tend to have a more severe disease, the immunosuppressed and children. And the complications can include bacterial superinfection, skin scarring. If it gets near the eye, that can be very problematic. It can cause scarring of the cornea. So anytime that you see lesions near the eye, you want to get it tested as soon as possible. And if it really looks like classic monkeypox, empiric treatment would be warranted. And that is something we definitely do empiric treatment in cases that look absolutely classic for it. Pneumonia, dehydration, sepsis, even encephalitis have been reported as complications as well. Okay, so how do we test, treat, and prevent this? I'm going to present some material. It is based on CDC and WHO. Laboratory testing is not that complex or difficult, really. It's based on the PCR technology, nucleic acid amplification testing. You swab the lesions. You don't need to unroof the lesions. You do not need to unroof any scabs or anything else. Simply swabbing the surface of them is adequate. It's good to do more than one site if you can. And then you just need access to a laboratory that can perform the PCR testing. And I'm not entirely sure where that happens. Perhaps we could talk about whether that is done locally right there in Trinidad. I suspect it is. Treatment, fortunately, we do have treatment. The treatment is something called tecovirimat or TPOX. This is one that, we don't have a whole lot of data about its efficacy in humans, but we have pretty convincing efficacy from a macaque model that suggests high efficacy. We've been using this in the clinic where I work, and we have been seeing success with it. We've been seeing it, as being very well tolerated. And people reporting that, their symptoms get better faster. Hopefully, it shortens the duration of shedding and reduces transmissibility. We don't know that yet. One thing to know, though, it needs to be taken twice daily with a high-fat, high-calorie meal. And that can be a bit of a burden potentially for people with food insecurity. So for some of our patients, we are providing them with essentially like peanut butter is a good source of fat and calories, things like that for the duration of treatment, which is 14 days, so that it can be absorbed properly. So when do we treat? Well, the CDC put out some guidance with a whole lot of recommendations about who to consider treatment. It includes anybody with a history of atopic dermatitis or eczema, for example. So it's a fairly broad treatment. And honestly, if the supply is adequate, there's not much reason to not treat, right? Because it appears that individuals get better sooner. They're much less risk of getting ill. And there doesn't seem to be much a downside. This seems to be a very well tolerated and safe treatment. So I think the only real limiting factor has been availability. But where there's availability, we've been pretty liberal, frankly, with treating this condition in the clinic where I work. That's been well received. Now, in terms of prevention, there are a couple of vaccines out there. These are vaccines that were originally developed for smallpox, but they are definitely active against monkeypox as well. Historically, there was one called ACAM 2000, not currently being used, but people may have received it in the past as smallpox vaccination, and that very likely continues to confer protection against monkeypox. The currently used vaccine is called Jynneos. It consists of a live, non-replicating vaccinia virus. So it is live, but it cannot replicate. So that really makes it a very safe vaccine. Thought to be effective 2 weeks after the immunization series of 2 shots. Mostly local side effects. It's safe in pregnancy, immunosuppressed persons. Interestingly, as I showed the data from the DRC, having been vaccinated against smallpox in the past very likely provides a significant level of protection against monkeypox. When smallpox vaccination was done and stopped sort of varies a bit from country to country, but if you've been vaccinated against smallpox, you may have the scar from it, and it tends to be a kind of an indented scar as shown on the bottom. Pretty similar to the BCG scar, but the BCG scar tends to be more elevated for some reason. this is just showing how, very few contraindications for using this Genios vaccine, only if there's a severe vaccine component allergy. And the reason it works is probably because, smallpox is caused by the variola virus. Now, we use the vaccinia virus as the basis of our vaccines, and that to protect against smallpox. Monkeypox is actually much more closely related to vaccinia than is smallpox. So it's not really surprising that we see the smallpox vaccine, i.e. vaccinia, being effective against monkeypox. So who do we immunize? We want to focus on immunization as a post-exposure prophylaxis for high-risk contacts of individuals who have been diagnosed with monkeypox. For unexposed individuals, the vaccination might be called pre-exposure prophylaxis. To date, we've been trying to, at least initially, prioritize high-risk groups, mostly based on a limitation of supply. Now, the supply has increased significantly, especially since we figured out that we could give this intradermally rather than intramuscularly, and the intradermal route allows us to expand. Rather than one shot going to one person, one vial can be used for 5 individuals. So it has quintupled our supply by simply adopting a different route of administration. There haven't been any cases of monkeypox transmission to healthcare providers, and so we're not routinely recommending that healthcare providers get this, at least insofar as it is relevant for occupational exposure. However, we really are treating monkeypox suspected cases the same way we treat and manage suspected COVID cases in terms of our personal protective equipment. So, for example, in the clinic where I work, individuals suspected of having monkeypox is immediately escorted to a room by themselves, and any provider going in should wear gowns, gloves, N95 masks, and eye protection with the usual donning and doffing procedures to make it very safe for preventing transmission or spread. There's some advice that we can give to people who have been exposed to monkeypox to monitor for symptoms, sort of in a similar way that we do for COVID-19 exposures. I'm going to present very quickly some public health messaging around monkeypox that I think is worth considering. I don't know what Trinidad has been doing, but I think there are a few key points that are worth emphasizing. It's a rare disease. This is what we say here in the United States. It's a virus not commonly seen in the US, spread through close physical contact. It can make you sick, but it's very rare to have a bad outcome. Most people recover without complications in 2 to 4 weeks. There is a vaccine, and anyone who has been in close contact with someone who has monkeypox is at risk, should be considered for vaccination and monitoring. How it spreads: skin-to-skin contact, via infected lesions or fluids. It seems to occur mostly through intimate contact associated with sexual behavior, epidemiologically among gay, bisexual, and other men who have sex with men. So just to summarize the key points, fortunately, the monkeypox epidemic has recently eased a bit in most parts of the world. Currently, it remains highly concentrated in gay, bisexual, and other men who have sex with men, with characteristics of what I would call a sexually transmissible infection, meaning intimate skin-to-skin contact with involving someone with lesions appears to be the primary means of transmission. We can recover the virus from other bodily fluids, but we don't know exactly what that means yet in terms of transmission. Clinical presentation seems to be a bit different from that seen in past limited outbreaks. Specifically, the prodrome may be mild or absent, and the lesions are often appearing right at the site of inoculation, rather than just seeing sort of disseminated skin lesions. The presentation can very much mimic other derm conditions, other STDs, so a high index of suspicion and low threshold for testing are warranted. This is a typically self-limited disease, but can often be painful. Complications can occur. Treatment and vaccines exist. They're still in short supply. No documented case of occupational transmission have occurred to healthcare workers, but we all need to be using standard PPE precautions, similar to COVID precautions around individuals known or suspected of having monkeypox. So I'm going to stop there and give ourselves some time for discussion and questions.
Okay, thank you, Dr. Behrens, for that fascinating and very informative presentation, as usual. While we wait for other persons to come with some questions, I'll just pop one in quickly. In terms of the COVID-19 vaccination, the bivalent vaccine that Pfizer and Moderna are producing, is there any suggestion that any other companies trying to come up with their own bivalent or maybe multivalent vaccine at this time?
Yeah, good question. I'm not aware of any. I wouldn't be surprised if another company is trying to do that. But having said that, I think the messenger RNA technology really lends itself to being able to rather quickly, change the components and the key genetic material of the vaccine, right? Because the way these vaccines work is you're injecting messenger RNA that corresponds to a key part of the virus you're trying to immunize against. Well, with new variants, we can easily, sequence what's different in, say, the spike protein coding of the new variants, and we can take that, generate the corresponding messenger RNA, and simply plug that into the existing vehicle that is used to give these messenger RNA vaccines. So I feel like the COVID and Moderna vaccines are perhaps ideally suited for relatively rapid updates to the genetic material encoded, whereas other vaccines, they use sort of a more traditional, historically common approach to vaccine production that may be a more cumbersome process. And perhaps that's why Pfizer and Moderna are the first ones out of the gate, so to speak, with Omicron targeted vaccine boosters.
Thanks, Dr. Behrens. So I'll open the floor for any other questions. Remember, there is no such thing as a bad or silly question. This is a safe space for asking questions. And if you can't unmute where you are, feel free to enter your question in the chat box. Okay, nothing yet.
Yes, silly questions are very much appreciated. What about the, while we're waiting for questions, what about the availability in Trinidad of vaccinations or treatments for monkeypox? Is that something that's present, coming? What's the relative availability, et cetera?
So, from what I understand, the ministry has been putting structures in place in case we get our first case. We have not as yet.
Oh, wow.
Yeah, thankfully. There's a special quarantine place that opened during the Ebola outbreak that even also converted to a monkeypox isolation facility in case we get the first case. I'm not sure about vaccination and treatment availability at this time. I don't know if anyone in the audience who knows anything more about that issue.
Well, that's terrific that you don't have any cases yet, or at least as far as you know. It is worth noting that there are, like that Belgian study, there were some cases that had been misdiagnosed empirically as something else. And then when they went back to, they realized, oh, that was actually monkeypox. But then it resolved on its own.
We had a couple of scares in the clinic, but none of the persons had a travel history or had any contact with someone who was from outside the country. So, it turned out not to be monkeypox in the end. But I think we were on high alert. Any odd-looking rash, we always just double check to make sure it's not monkeypox.
Yeah, terrific.
Hi, Ms. Philip. Sure, I see your hand up. Go ahead and ask the question.
Hi, thank you. I know you mentioned in one of the cases that the person wasn't treated. I think you showed some images. Is there any adverse effects if somebody is left untreated, like they were misdiagnosed? Because I think that person was treated for syphilis at first. I'm not sure if I can't remember if you mentioned anything about any adverse effects if somebody is not treated.
Right. Well, I mean, usually not, because for the vast majority of people, this is a self-limited illness without any complications, apart from maybe some, scarring of the skin or hypopigmentation that is a typical consequence of these kinds of lesions. There can be complications. I think a bacterial superinfection is one of the more common ones. Corneal scarring is one of the, more concerning potential complications, which is why we get very nervous if there's any appearance of lesions, on the face or especially near the eyes. There have been, some rare, I think a few, case reports of neurologic dissemination. Again, there was one individual that I'm aware of here in the United States who actually died from it. That individual was very immunocompromised. So for the most part, no, there are no serious complications of not getting treated. And I think it has to be acknowledged, we don't have enough data yet to truly confirm just how much treatment helps in terms of preventing illness. We know, however, that in the macaque model is very effective in terms of preventing death. So we know that the medication works fairly elegantly in terms of disrupting the life cycle of the virus, fairly similarly to the way HIV medications disrupt the life cycle of HIV. So we, I think have reason to expect that this treatment would have a significant impact in terms of preventing serious complications, reducing the risk of complications. We just don't have the data yet to confirm just how much that impact is.
Okay, thank you so much for your answer.
Mm-hmm.
Hi, Dr. Behrens. Another quick question from me. One of the things that I was thinking about was the possibility, the cases are coming down, but in terms of stigma and discrimination against persons who develop monkeypox, particularly given the early association with men of sex with men and immunocompromise, have there been any reports of that sort of thing going on? Because my concern might be, especially in a small country like ours, that someone who presents with a rash and worried it might be monkeypox, and you can't really, if it's in a place that can't be hidden, they may choose to hide because of fear of being stigmatized or fear of being discriminated against.
Sure. Yeah, I think that's a very legitimate concern, and we saw and continue to see that play out with HIV, for example. I'm not aware of that, where I work, but here in Seattle, I think we're in this little bubble. I think sometimes sort of increased tolerance, and so there's just not a lot of stigma towards gay, bisexual, men who have sex with men, transgender, queer, etc. That tends to be fairly well accepted. I think there's certainly was and still is about a bit of sort of fear and concern about risk of monkeypox. I know there's some definite concern among the broader community of, oh my gosh, it's could this start, if this gets into like daycare centers, think about how much kids interact with one another and with towels and blankets, and could we start to see outbreaks among children? A lot of parents concerned about that. And that could still happen, but for now, it still seems to be confined to that one epidemiologic group. I do think your concerns are very much warranted, and that's why I do wonder if, could there be cases and people are simply not presenting to care because they don't want it to be known.
Conrad, thanks, Dr. Behrens. Conrad, I see your hand raised. Go ahead.
I just saw a question in the chat. Persons with comorbidities or untreated FTIs are more likely to experience complications, but what is the likelihood of dying from monkeypox?
Sure. Well, overall, I think it's less than 1%. I think that's about all we can say. It's just these occasional case reports. I'm aware of one death here in the United States. I'm sure there have been others in other parts of the world. I don't have the exact numbers, but I do know with the C2 clade, from which our current outbreak derives, historically the case fatality rate was 1% or less. And
there was a question submitted to me: for an adult who was never vaccinated against smallpox, should they try to obtain the vaccine at this time?
I don't think you really need to, unless you're, in a high-risk group. High risk is kind of a judgment call. But like I said, currently, this really does seem to be confined to gay, bisexual, other men who have sex with men, who are sexually active, with typically multiple sex partners, or having sex in group settings, those sorts of things. So if you're not a part of that demographic, I really don't think it's necessary to seek out the vaccine at this time. I think it's also worth taking into account, frankly, the local epidemiology in Trinidad. And if you're just, not seeing it yet in Trinidad, there's less of a urgency to getting it unless, I don't know, you're anticipating travel to a region where it's more prevalent.
Okay. All right. So we're just about a minute left. So I think I'm seeing one quick question. No, sorry, that was the last question I saw. All right. So again, I think it's about time we can wrap this session up. So again, Dr. Behrens, thank you for that talk, and thank everyone who participated for their questions. They were all really interesting questions. We will be back in 2 weeks' time on a Thursday at 2 p.m. for another MRF HIVSTI session. I see Conrad has already uploaded the slides, so they'll be there for anyone who wants to go through the slides, and the video should be posted by Monday. So again, everyone have a safe weekend. That's it from me at MRF HIVSTI Echo. Be safe and be well. Take care, everybody. Have a great day.
Thanks, everyone.